permission, I'm starting with today's session now. Greetings and a warm welcome to all the dignitaries present here. I'm Shwastika from Team Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet is India's most trusted and widely used digital platform, offering a multitude of ensuring services especially for the doctors. Clarnet is ready to be chosen as a digital partner for this event organized by Liver Transplant Anesthesia and Critical Care in India. So today's focus would be acute on chronic liver failure ACLF. And now I would like to invite Dr. Susan ma'am to take over. Over to you, ma'am.
Okay, thank you, Swastika. This is Dr. Susan here. Welcome, warm welcome to everyone for today's Litracsi Webseries session. So this is a journal club on the paper Acute-On-Chronic Liver Failure, the Kyoto Consensus Steps from Asia. And this is a really big paper, and I'm going to be discussing about the topics relevant to liver transplant anesthetists and intensivist. And I'm very happy to introduce Dr. Naveen here. Dr. Naveen is a consultant hepatologist from Rela Institute. He is one of the co-authors of this paper. He is someone who is very passionate and enthusiastic about research on ACLF and is currently involved in multiple trials in the same. It's great to have you here, Dr. Naveen. Thank you for joining us today. And with that, I will be proceeding to this paper discussion. So this is the topic is acute on chronic liver failure, the Kyoto Consensus Steps from Asia. This was written by Dr. Ashok Chowdhury et al. And was published in the Hepatology International in February of 2025. So the problem statement which was recognized was the presence of multiple definitions for ACLF. And there were inconsistencies in the diagnosis, management, and research related to ACLF. So this was recognized, and this led to the urgent need for collaborative research to work on non-transplant therapeutic strategies and improving the liver transplant outcomes. In order to manage this, the APASL initiated a global collaboration. 16 questions were recognized and addressed, and the consensus was presented at the APASL annual conference in Kyoto in the March of 2024. So in order to understand ACLF better, a little bit of introduction to the natural history of liver disease. The liver disease has two components, as you all know. There's a compensated stage and the decompensated stage. The compensated stage is the asymptomatic period, which has a long survival of around 10 or more years, while the decompensated stage is characterized by symptoms, and they have a very low median survival of less than 2 years. So the term decompensation includes a bilirubin value of more than 3 milligrams per deciliter, clinically detectable ascites, overt hepatic encephalopathy, and episodes of portal hypertensive bleeding. While the term further decompensation is used to identify second portal hypertensive driven events such as recurrent ascites or second event of an ascites, hepatic encephalopathy, and UGA bleed and or jaundice. While all recurrent episodes of bleeding, worsening ascites were all considered as further decompensation and recurrent encephalopathy along with development of SVP and or HRS. So it is important to recognize or understand the spectrum of decompensated liver disease in order to treat and manage your patients better, and also to develop research protocols. So the four spectrums identified include the non-acute decompensation state, acute decompensation state, further decompensation, and then you have the ACLF. The acute decompensation state, as we all know, is there are no symptoms here. In the non-acute decompensation phase, there is no acute insult, and there is an underlying cirrhosis always diagnosed, and there may not be a prior decompensating episode, and they have very less mortality, higher chances of regression or recompensation, and there is no need for a bridging therapy. The term acute decompensation includes more gradual form of development of jaundice and ascites, HE, variceal bleeding, which requires medical attention but may not require hospitalization. Here, an acute insult is present, and an identifiable insult is present in identified in almost 40% of the cases. And the time from acute insult to presentation will be within up to 33 months. And there will be an underlying cirrhosis diagnosed or undiagnosed. And these patients also have a high mortality ranging between 45 to 60%, while regression and recompensating events are limited, and the use of bridging therapy is limited here. In the further decompensation spectrum, it is similar to acute decompensation, whereas there is lesser chance of regression and recompensation here. And there comes the ACLF spectrum, where you have an acute insult and an identifiable insult in 70% of the cases, with very short duration of presentation from insult to presentation within 28 days, and the presence of advanced stages of fibrosis, F3, F4 stages, or early cirrhosis. And the patients may or may not be diagnosed at the time of presentation, and they have very high mortality up to 70%. Here again, you have chances of regression and recompensation, and bridging therapy is often helpful. So certain new terminologies are defined here, where recompensation and reversal. The term recompensation was first introduced in the Bavino 7 consensus. So this is actually challenging the traditional perspective of decompensated cirrhosis being considered as an irreversible endpoint. So there is a new paradigm for patient management and prognosis. So what is recompensation? It is a state where the patients, due to effective control of etiology and management of the complications, they show an absence of clinical decompensating events for an extended period. So this will be seen with improvement in the laboratory and clinical features, which are similar to compensated cirrhosis. So what is the criteria for this? There is removal or control of etiology. There is resolution of clinical decompensation such as ascites and HE and absence of variceal bleeding. And you see a sustained improvement in the laboratory values as well. Now, what is reversal? So, reversal is the terminology which is used with regards to ACLF patients. So, here, better than recompensation, reversal is used because most of the patients have advanced fibrosis and not cirrhosis. So, the ARC defines reversibility as a decrease in the bilirubin below 5 milligrams and reversal of coagulopathy to INR less than 1.5 and no encephalopathy with or without resolution of ascites. So, what is the evidence for this from the current literature? So from the ARC database, it is seen that 70% of survivors have had reversal of ACLF by 90 days, and which was maintained for at least 1 year. And the median time to reversal of jaundice and coagulopathy was around 30 days. Baseline albumin, ARC score, and transient elastography predicted long-term reversibility. While the canonic study has shown a reversal data in the ACLF 1 grade, around in 54% of the population. In the ACLF 2 grades, around 35% had reversal, while in ACLF 3, only 60% had reversal. Here, the median time for resolution was 14 days, ranging between 1 to 28 days. So reversible decompensations had in the grade 1 state had a lower risk of progressing to grade 3, and liver-related organ failures such as coagulopathy, hyperbilirubinemia, and cerebral failure had higher risk of progressing to grade 3 ACLF, according to the canonic study data. So again, coming back to the spectrum of liver injury and failure. So a patient with compensated cirrhosis with early stage or advanced stages of fibrosis can develop ACLF or decompensated cirrhosis in the presence of a precipitant. In the case of an ACLF patient, within 6 months, he can either reverse or he can proceed to liver transplant, or in the absence of the above two, he can move on to, he can worsen to death or multi-organ failure and death. While the patients who have had reversal can again develop ACLF and then will require an liver transplantation or can worsen to death. Similarly, in the decompensated cirrhosis, it can be either an acute decompensation or a non-acute decompensation. When the etiology is getting treated or is treated within a span of 12 months, the patient can have a chance of recompensating and regression. However, the mechanism is still not understood. The mechanism for regeneration is still not clear, or they can progress to developing HCC or again repeated recurrent episodes of portal hypertension, further decompensation, or they can even progress to ACLF. So this is the spectrum of liver injury and liver patients in cirrhosis. So coming to the recommendations given in the consensus. So for the development, so acute decompensation definition is defined as acute development of complications within 4 weeks of onset and requiring non-elective medical attention, while further decompensation is any episodes of AD in a patient with prior decompensation. And these patients have high mortality in the absence of recovery or liver transplantation in 3 months. And these are all strong recommendations. While patients with AD and organ failure have very high short-term mortality. Again, this is a strong recommendation, and you can see that the level of evidence here is moderate in all of these recommendations. Concerning recompensation, it is defined as the removal of or control of etiological factors with sustained absence of decompensating events for more than 1 year in patients who have already decompensated cirrhosis, coupled with along with an improvement in the liver function test. However, we don't have enough evidence with regards to this, and this is a weak recommendation. Also, with regards to reversal, the timeline for reversal of ACLF is maybe considered at 6 months, and the patients achieving reversibility by 90 days are considered as early reversals. Again, this is a weak recommendation. Further recommendations with regards to ACLF grades. So baseline ACLF grade and any shift in the grade in the first week can identify patients who are likely to reverse. This is a strong recommendation. Reversal of ACLF syndrome is an important therapeutic goal, and it can be considered for delisting patients from the wait list. A strong recommendation again. Patients who achieve reversal can develop ACLF again, and all subsequent episodes of ACLF should be evaluated and managed like that of the patients with the index presentation. So the Kyoto consensus has now provided a unified definition in order to aid further research with related to ACLF. So now ACLF is a distinct reversible syndrome characterized by rapid onset liver failure, where bilirubin is more than 5 and INR is more than 1.5, which is followed by ascites and or encephalopathy within 28 days, associated with or without kidney dysfunction in a patient with chronic liver disease or CLD, and is associated with high mortality till 28 days. And for defining ACLF, a period of presentation within 4 weeks should be considered, and this is a very strong recommendation, and this comes with a high level of evidence. So two types have been identified by the Kyoto consensus group. So there is a type A and a type B. The type A ACLF is category is basically the APASL criteria, while the type B is the EASL and the ASLD criteria. So in the type A, so in the type A, you have patients who are first-time presenters, who do not, which this do not include patients who have had previous decompensations or extrahepatic insults, and this is often considered reversible, and they consider infection as a consequence rather than a precipitant of ACLF. And the mortality is slightly lower here, 30 to 40%. While the type B is will include type A as well as any previous decompensations and organ failures caused by hepatic and extrahepatic insults, including infection. So here the 28-day mortality is higher, 40 to 50%. So acute worsening due to hepatitis A, E, B flare, alcoholic hepatitis, autoimmune hepatitis, or drug-induced liver injury are all characterized as hepatic insults. While extrahepatic insults includes bacterial infection, upper GI bleed, surgery or surgery, and etc. So the categorization of ACLF is again a and a strong recommendation. It comes when the following high level of evidence. Considering infection or sepsis in the natural history of ACLF. So, this is known to precipitate organ failures. Even in the absence of hepatic failure, this is associated with high mortality. And sepsis precipitated organ failure is largely driven by inflammation. So, one of the common types of infections that we deal with we are SBP. UTI, pneumonia, bacteremia, and SSTI. So, bacterial infection related ACLF more frequently were seen in younger patients, in male patients, and in patients with alcohol-related cirrhosis, and those with a higher baseline MELD. Around 25 plus or minus 11. So, as you all know, as the number of organ failures increase, the survival rate decreases in ACLF patients. Specifically considering hepatotropic viruses. They have given us a table to differentiate between hepatitis, acute liver failure versus ACLF due to HBV deactivation. So here in the hepatitis B induced ALF, the jaundice to encephalopathy interval is 4 weeks. Similarly, it is the same in ACLF due to HBV reactivation. Whereas the stigmata of CLD is not there in the ALF scenario, whereas the patient can have ascites with or without splenomegaly. HBV DNA levels are lower in the ALF category, while they are higher in the ACLF. Concomitant bacterial infections occur very late in ALF, while they are early or superimposed in the ACLF. Spontaneous recovery is not common, requiring emergent liver transplantations in the ALF scenario, while spontaneous recovery is rare, and antivirals play a definitive role, and urgent liver transplantation is considered urgent in the ACLF due to HBV reactivation. So HBV reactivation could be spontaneous or induced by either chemotherapy, withdrawal of antivirals, or in the presence of concomitant viral infection. While hepatitis A, E, SARS-CoV virus, or other frequently recorded triggers of ACLF in the cirrhotic population. So, diagnostics of infection, sepsis in ACLF. So, there are chances of the culture positivity rate is around 57%, while 56 demonstrate fever as against 86% in the non-cirrhotic population. The use of CRP is questionable, while moderate CRP rise may not predict infections, but high CRP levels at presentation or persistently high CRP levels may provide a better evidence of infection in this scenario. Procalcitonin again is a good prognostic indicator for the course of hospitalization and could be associated with the grade of ACLF triggered by infections. So leukocyte ratios such as monocyte lymphocyte ratio, neutrophil lymphocyte ratio have also been shown to be useful in predicting infections and deterioration. So these are all some of the markers which are being explored in the current and future studies. So, coming to recommendations with regards to infections in individuals with definitive hepatotropic acute insults, bacterial infection is unlikely to precipitate ACLF. Bacterial infections can be presumed as a precipitating event of organ failure in the absence of other identifiable causes. Spontaneous reactivation of Hep B may be defined as a DNA levels more than 20,000 or reappearance of HBsAg positivity, and a flare of ALT more than 5 times the upper limit of normal. So HPV reactivation from occult HPV infection, chronic liver diseases should be carefully evaluated for the ACLF diagnosis. Acute viral hepatitis due to Hep A and E is common cause, and early screening of suspected patients for these infections is highly recommended. Moving on to organ dysfunctions. So each of the organ dysfunction and failure has been clearly defined. Liver failure is defined as bilirubin more than or equal to 5 and or INR more than or equal to 1.5. Respiratory dysfunction is you need for non-invasive oxygen supports for hypoxemia with the PF ratio of more than equal to 200, while requirement for mechanical ventilation with PF ratio less than 200 is considered respiratory failure. Circulatory failure is defined as requirement of vasopressors to maintain MAP more than 65. Lactate is an integral component of the ARC score, and it provides a reliable assessment of the degree of liver failure in ACLF. So you can see that respiratory failure and circulatory failure, the evidence is low, and it's a weak recommendation. However, respiratory and circulatory failures in decompensated cirrhosis are associated with high mortality, and for this, evidence is high and it is a strong recommendation. So, need for mechanical ventilation, while the least common among the extrahepatic organ failures, it is strongly associated with poor post-transplant survival, and this should be considered a relative contraindication to liver transplantation. Again, moderate level of evidence, but a strong recommendation. Moving on to AKI, the incidence of AKI is higher, and the use of serum creatinine, absolute serum creatinine, should not be considered, but rather the urine output for diagnosis and staging. High evidence, strong recommendation. There is rapid progression of AKI and poor response to vasoconstrictors and volume expansion in ACLF patients. And though HRS is considered a functional AKI, in patients with ACLF, HRS may frequently coexist with cholemic nephropathy and occur in the presence of tubular dysfunction because of severe systemic inflammation. What about cerebral failure? So, overt cognitive dysfunction there includes grade 1 and 2 HE, while advanced cognitive dysfunction, that is cerebral failure, encompasses grade 3 and 4 encephalopathy, and this is considered part of liver failure, and the rest all of the organ failures are considered as the extrahepatic organ failure. So we have there is a paucity of existing data, and more studies are required to understand the sequence of the organ failures and the reversibility of the individual organ failures in ACLF. However, respiratory failure requiring mechanical ventilation and circulatory failure requiring vasopressor support are indicators of utility in patients with ACLF and are less likely to recover. So these events are considered as terminal and irreversible. Moving on to acute insults. So, alcohol is the most frequently identified acute insult. Acute alcoholic hepatitis and alcohol associated ACLF are defined by significant alcohol intake within 8 weeks. So, the next frequently identified precipitant is hepatitis B. Hepatitis A, E, and C are showing decreasing trend. While drug-induced ACLF is being considered, the prognosis of severe drug-induced ACLF is poor in the absence of liver transplantation. And ATT and CAM-induced ACLF are the frequent causes. In case of autoimmune hepatitis, steroids are the drug of choice, and there is no contraindication for the use of steroids in ACLF. Other less frequent causes or precipitants of ACLF include acute hepatic vein thrombosis, occlusion of tips, HV stent, acute portal vein thrombosis. But however, the evidence for this is low, but these are all considered strong recommendations. So anticoagulation tips can be considered in Buchiari related ACLF in selective patients. And other less frequently noticed precipitants are variceal bleeding, post-TACE, and post-hepatectomy liver failure. With regards to infections in ACLF, there is debate regarding the use of antibiotics either empirically and the timing of de-escalation and discontinuation. So empirical antibiotics do not have any mortality benefit, and antibiotics should be discontinued in hospitalized patients if no infection is identified. This can be guided by your culture sensitivity at 24 to 48 hours and when the patient is improving. So this is again a strong recommendation. So there are still unknown causes. So they are less prevalent in the east west compared to the west, so where it is 15% versus 40% in the west. So moving on to the treatment of ACLF, a dedicated liver ICU with multidisciplinary team is helpful. The golden window for ACLF worsening, stabilization, or reversal, and the time frame for selection of patients for liver transplantation is 7 days. So nutrition plays a pivotal role, and sarcopenia is a risk factor for 90-day mortality. Use of omega-3 fatty acid infusions in the prevention of ACLF has been strongly recommended, and there is moderate level of evidence for this. Use of antivirals can be done without waiting for the DNA levels when your evidence is strong. A 2 log reduction in the HBV DNA levels after 2 weeks of therapy reduction is associated with improved survival and should be performed whenever feasible. Steroids have been reported to improve short-term survival, irrespective of the type of steroids used in patients, especially in patients with MELD scores ranging between 25 to 39. So patients with an ARC score above 10 at baseline were found to be poor responders to steroids, and they were shown they had higher mortality. Use of steroids in autoimmune hepatitis related ACLF is a strong recommendation again, especially in patients who do not have any contraindications and those who do not have overt HE. Steroids may be used in patients with biopsy proven drug induced ACLF who have evidence of autoimmune disorder. So, close monitoring is suggested for patients who receive steroids. A short course for around 4 weeks of steroid therapy is suggested, but the duration is based on the clinical recovery and the clinician's judgment. TP may be performed in patients with ACLF as a bridging modality to liver transplant, and the number of sessions and the type should be based on clinical judgment. So, this again has a moderate level of evidence, and this is a strong recommendation. TPE can provide a window of 30 days to bridge a patient with ACLF to liver transplant. See, if you see the evidence available, or most of the evidences have shown improved survival at 28 days, but not at 90 days. And this meta-analysis, where around close to 4,000 patients were analyzed, they have shown again improved survival with TPE at around 28 days. So proving or providing a platform for the patients to get a window for bridging to liver transplantation. So centrifugal TP is preferred over membrane TP, and the number of sessions required can be individualized. We still don't have a robust data or guidelines for this. So moving on to the most important part, the liver transplantation in ACLF. This is considered the only potentially curative option with excellent outcomes. The post-transplant survival is dependent on the grade of ACLF. ARC data shows that at baseline, the liver transplant eligibility is seen in around 35%, which increases to up to 61% at the end of 1 week. And the 5 year survival post liver transplantation is as high as 80 to 95%. Liver transplant waiting list mortality due to delisting of for organ failures and sepsis have considerably come down from 80% to almost 25% due to improved ICU care and organ supports. Although timely liver transplant can provide significant survival benefits, significant healthcare utilization is seen in these patients both pre and post liver transplantation. So, regarding transplant window and prioritization, the duration of abstinence, alcohol abstinence, should not be considered a criteria, should not be a criteria for selecting patients in alcohol-related ACLF. So, this is a strong recommendation. Patients should have a demonstrable psychological stability following a thorough psychosocial assessment before considering for liver transplantation. High level of evidence and strong recommendation. Liver transplantation is the only definitive therapy for grade 2 and 3, and these patients should be transplanted early. Transplant benefit in ACLF should be assessed based on the severity of acute liver injury, the reversibility of the underlying liver disease, and the prognosis of the associated extrahepatic organ failure. So an ARC score of 8, a grade 2, is associated with non-transplant mortality risk of around 20% at 4 weeks. And this is considered as the minimal ARC score cutoff to ensure benefit of early transplantation. This is a weak recommendation. In LDLT dominant programs, counseling and live donor evaluation should be started early after the initial assessment so that delays are avoided and early liver transplantation and benefit can be provided to the patients. Some management recommendations regarding management strategies. So donor selection and ideal GRWR in LDLT as well as graft steatosis are considered crucial for better outcomes in in ACLF patients. However, this has low evidence and this is a weak recommendation. A minimum of zero point 0.8 GRWR is suggested with donor age ranging between 18 and 50 and a minimal steatosis of up to or less than 15% and is suggested for these patients. To reduce the occurrence of sepsis, a consideration can be made to lower the dose of corticosteroids given at the time of reperfusion. Again, low level of evidence and weak recommendation. Intraoperatively, restrictive or goal-directed fluid therapy is considered beneficial over liberal fluid therapy. Low evidence and weak recommendation. Also, the intraoperative use of CRRT in patients with renal injury and those with metabolic complications is suggested as a weak recommendation. Moving on to post-transplant immunosuppressions in patients transplanted for ACLF and renal dysfunction. A CNI sparing strategy and early introduction of MMF and everolimus after ruling out surgical complication is shown to predict greater survival without the increased risk of rejection. So this comes out as a strong recommendation, and there is moderate level of evidence for this. And in patients with ABOI incompatible liver transplantation, there is high risk associated with this, and this should be avoided. And this is again a very strong recommendation. Long-term post-transplant complications of immunosuppressive medications are the same in ACLF and non-ACLF patients. This has got moderate level of evidence. So what about unsuitability, contraindications, and futility of liver transplantation in ACLF patients? So post-LT's survival of less than 3 months or in-hospital mortality is considered as a futile liver transplantation. So the day 3 to 7 scores, CLIF-C ACLF score of more than 64 or ARC score of more than 13 is considered futile. So, what are the factors that are associated with this, or associated with futility following transplant? Uncontrolled sepsis with or without two or more organ failures, advanced stages of renal dysfunction, renal failure, need for RRT, PF ratio of less than 150, noradrenaline requirement of more than 1 mics per kg per minute, serum lactate levels of more than 4 are all considered conditions for temporary unsuitability to proceed for liver transplantation. This has got moderate level of evidence and this is a very strong recommendation. Factors again associated with adverse outcomes include in the pre-transplant period, the pulmonary component includes ventilatory status on ventilator with respiratory failure and ARDS, lactate levels persistently more than 4, in the kidney aspect, creatinine of more than 4 or increase of more than around 300% from baseline, need for RRT. Infections, again, infections with sepsis with MDROs, fungal, nosocomial infections, persistent shock, refractory shock, uncontrolled sepsis, low leukocyte counts prior to transplant are all considered unfavorable for the post-liver transplant outcomes. So in the clinical course, ACLF grading and high MELD scores are indicators of futility. And again, we discussed CLIF-C score and futility risk score of more than 8. The multiple scores have been demonstrated or available to assess futility. And longer ICU stays before transplant and the rate of progression of ACLF and the presence of organ failures are all other factors in the pre-transplant period, which can help us to assess outcomes following transplant. In the transplant related aspect, high donor risk index, intraoperative blood transfusions, or all other factors associated with adverse outcomes, and post transplantation rejection episodes and sepsis, multi organ failure are all considered factors, predictors of adverse outcomes. So with this, I've come to the end of my presentation. So further research are all or required, especially with regards to the role of steroids in ACLF, considering the various factors such as disease severity, patient characteristics, and the potential risks associated with steroid therapy. We still need data on the role of TP, especially with regards to the use of high volume versus standard volume and the choice of patients and the disease spectrum. Role of artificial liver support systems in ACLF, such as cytokines, bilirubin, bile acid filters, are all being explored. And further evidence is required, especially with regards to the ACLF reversal, predictors, and outcomes. Also, long-term outcomes of AKI, kidney dysfunction in ACLF, needs to be explored, and intraoperative management and immediate postoperative management in the ACLF patients are other areas where further research and robust guidelines are required. With that, I conclude my talk, and we'll be open for discussion. So I invite Dr. Naveen to share his suggestions on this, especially with regards to the use of steroids, sir. What do you think, or what is the role of steroids, especially in the management of ACLF patients in the ICU? And how do we choose patients, and what are the precautions that we need to take while using steroids in these patients?
Thank you, Susan. First, I congratulate you for taking this mammoth task of summarizing this entire consensus paper in 30 minutes. It's a really huge task in itself. Okay, answering your question, the role of steroids in alcoholic hepatitis related ACLF. That is so far that is the considered as the standard of care in severe alcoholic hepatitis, even though there are other therapies, but still the standard of care remains steroids. But when you off late, the more we understand, steroids are can cause more harm to the patient, especially when the patient is in ICU. Such a sick patient in ICU, steroids may be okay for patients who are walking in the OPDs when they are in the early mild phase of alcoholic hepatitis. Although the severe alcoholic hepatitis is defined as a MELD score of more than 20 without any other organ failures, especially the renal failure. And I recommend that we can use steroids for patients who doesn't have significant ascites. So
Sure.
the presence of ascites says the patient is having a significant gut dysbiosis. Thereby, there is a leaky gut. There is a significant leaky gut, and there is where the patients are more prone to develop more sepsis. That is, the more the gut is leaky, the patient is more prone for endotoxemia and systemic sepsis. These are the patients we should be very, very careful. And alcoholic hepatitis with not of much ascites and a good liver reserve may benefit from the steroids, but we should carefully select these patients where the patient should be of you should have a less risk of infection. So if there is a higher risk with respect to diabetes or the elderly age group, then we should be thinking about starting steroids in them. Also, second is the renal dysfunction. Presence of already a renal dysfunction in a patient, steroids should be very careful. And off late, there is a recent study. It's a study from India where they say the traditional steroids were given as a standard dose 40 mg per day for a month. They try for a week. They calculate the Lilly score. If the Lilly score seems to be responding, they consider to continue the steroids for a month. Now there is a change in recommendation where you calculate the Lilly score at the end of a week. You feel there is a response to steroids. You immediately taper the steroids rapidly, like 10 mg every week, and bring it down. Even by the end of the 1 month, you will be on low dose steroids. So that
Yeah.
to improve to reduce the risk of infections. So maybe the role of steroids, I don't think so. It's in the ICU settings when the patient is very sick with other organ failures. It is preferably can be used in OPD settings when the patient is still walking to the OPD. It's otherwise safe. There is no much ascites, no AKI, no risk for infections, there is where we can try steroids in such patients.
Yeah. Okay, yeah, we understand. So what about use of TPs? When would you suggest that, and how many cycles of TP would you provide for a patient prior to pushing them for liver transplantation? What would be your choice of patients for TP?
See, again, plasmid change is the commonest bridging therapy because it is why available at multiple centers.
Mm.
If you say that is the most common bridging therapy used here. And this also has a wide literature with respect only to the alcoholic hepatitis as well as the hepatitis B related on chronic liver failure, where we can the more the plex has been tried, and still there is a heterogeneity in the use of plasma exchange that varies according to the institution, their beliefs, and their risk appetite. Okay. So you work in a depends upon the centers you work. You work in a predominantly transplant center, and you find a patient who is sick and he is in multi-organ failure. He requires a transplant, and you have a transplant. You can proceed with a living donor transplant in say in another within a week's time. You don't want to put the patient to exposed to plasma exchange because there is a risk of infection. You want to keep your play the game safe. You treat the patients with antibiotics, avoid infections, and take the patient safely to transplant. Suppose you work in another center where you don't try, you can't do transplant, or the patient is not a candidate for a transplant. Maybe with respect to the donors, with respect to the finances, or they're not keen on transplant for any sure, or the patient is having a repeated alcohol recidivism, and there is poor psychosocial support to the patient, and you don't think that the patient is a good candidate for transplant. Then you are right in choosing an alternative therapy in the form of Plex. And my candidates for the or the recommendations where you choose Plex are the patients when they are in the heightened phase of inflammation. If there is a significant systemic inflammation, these are the patients who are actually it's a double-edged sword systemic inflammation, who are the better show response to the plasma exchange. And if they are not in without any infection, if they have a state of infections, maybe they may worse with plasma exchange too. And before selecting patients with plasma exchange, I am very cautious in selecting they don't have especially a pulmonary risk factor, or
Mm.
they shouldn't have any another slightest risk of pneumonia.
Mm.
So why we please select patients whose lungs are clear, and also who I feel the patient don't have any third spacing. And it means that patient does not have any capillary leak kind of syndrome. Like those things we carefully see. If these are not there, then the patient may be a candidate for a plasma exchange. But the main criteria we see is patient should have an inflammatory phase, and they should not have any infection, obvious infection, and the lungs and should be clear. And also, to a relative note, the patient should not go for volume overload with plasma exchange, so we should have a good renal outputs.
Yeah. Yeah, I think this message is important because for a patient who has to go for transplant, who has a donor and whose evaluation everything is getting done, I don't think we should waste time, or even if there is, I don't think there is any benefit in doing TP. What do you say about that? So should we just not do TP at all and then proceed for transplant? And
So,
uh,
you also again there's sometimes that we need
do
to
you think there will be, is there a role for transplant-free survival with TP in ACLF as we see in some ALF cases? Is there a role at all?
so there is a definitely TPE, as you also presented in the presentation, mentioned it. TPE improves the 28 days survival, but not the eventual outcomes. Okay,
Yeah, yeah.
so you get a little bit time for the transplant, but not you don't change the outcome of the disease with TPE. Okay.
Mm.
The thing is, when you have a chance to do a transplant at the earliest possible, then my message is no TB.
Do it.
For
Yeah.
some reasons, you need time for 2 weeks' time. The donor should arrive from somewhere else. They need a little bit time to go for it, and the patient otherwise is in a severe inflammatory storm, is having the day by day new organ failure is developing. Or the other reason is also a bulimic nephropathy,
Yeah.
where the high level of bilirubin actually obstructs the tubules and that causes the renal dysfunction. So these are the indications where yes, you can do a plasma exchange and take it on. There is no fixed dosages like 3 doses, 5 doses, but on an average, at least whatever the literature says, 2 to 3 doses is usually what these in ACLF patient they do tolerate. And by the time you see how the patient behaves to it,
Yeah. So
and
I think this is something that we still need a lot of data or evidence, from places who are doing this, because if we still don't know how many cycles is beneficial, what volume to give, is it high volume or standard volume, and what about reversal? Are we going to be looking for reversal, waiting for it, and then planning for transplant? That is something that do we have to keep in mind when planning for this?
yeah. With respect to reversal is usually where it's I won't say the percentage of persons going to reversal in such a case is usually less than 5%.
Mm.
And these are persons who, when the inflammatory phase settles, so even the timing of transplant in a patients of ACLF, usually you decide at the end of first week. You need to give
Yeah.
1 week time. Okay.
Yeah.
So by the in the meantime, you evaluate the donor, you keep the optimize the patient and see how the patient behaves at the end of the week. In the week's time, you will know whether the patient you feel there is a chance whether he is going to settle. You treat the inflammation. Maybe you did the bridging therapy with plasma exchange. You see how the patient behaves. Maybe at the end of the week, if you feel the patient improves, you are still justified to wait for another week
Right.
or so.
Yeah.
Because now you are ready, everything ready with the transplant. Any day if the patient goes for again goes down, you are good straight away. You can go for the transplant. So
Yeah.
with that point of time, you may wait. Okay, but so that's why I usually say the golden window period of a week in a patients with ACLF.
Yeah.
But this for with respect to reversibility, this usually happens only in alcohol or the
Mm.
viral related etiology. Now, none of the other etiologies may show such a drastic response, and also an autoimmune hepatitis.
Autoimmune. Yeah.
These are the
Mm.
three usually response. Okay, not the EASL ACLF or the type B ACLF, which usually there is no point of reversibility there.
Mm. Okay.
And
And yeah, sir, moving on to renal dysfunction in ACLF patients. So now, how does the renal dysfunction improve post-transplantation? And who are all the patients that you will choose for combined liver transplant? Do we even consider combined liver transplantation in ACLF, or are we going to give the patient a chance to recover post-transplant, post-liver transplant?
see, indication of combined liver kidney transplant, the CLKT itself, is still controversial. Okay,
Yeah,
in general, but
yeah,
with respect to ACLF, it's still you need a lot of evidence.
mm,
Everybody goes based on their personal or institute experience. Okay,
yeah,
with respect to renal dysfunction and transplant, you obviously there is among the pointers, among the markers for a poor outcome post in ACLF patients after transplant. The one of the marker was creatinine more than 4, or the presence of renal replacement therapy, or
yes,
4 times the rise in creatinine from the baseline. So all these were pointers towards a poor outcome post transplant.
yes,
See, you do a you are justified in doing a transplant in a patient. Don't look at the mere numbers. No absolute creatinine number actually should be a contraindication rather than the trend of increase or the trend of decrease matters.
mm,
And a patient with oliguria, anuria will do worse than a patient who is non-oliguric AKI.
okay, mm,
And the type of AKI matters a lot. If the cause of AKI is hepatorenal syndrome, and you are still you can go ahead with a isolated liver transplant. and the patient will show significant improvement post-transplant.
Yeah.
The cause of AK is coulimic nephropathy. They also still, because the coulimic nephropathy, the basic pathogenesis is high bilirubin levels in the blood that damages the tubules. So even
Yeah.
then, the chance of recovery of the native kidney is good, provided you do early transplant rather than waiting for a long time.
Long time.
And whenever you deal with an ATN, acute tubular necrosis, maybe preceded by the sepsis or preceded by the other CAM drugs, what that has
Mm.
been done, then the chance of recovery is less.
Okay.
So we choose patient going for a transplant if there is not by the mere number. We see the overall trend, whether it is an increasing trend or the decreasing trend, whether they are oliguric or non-oliguric, and also the cause. If you are just by doing hepatorenal syndrome or the polemic nephropathy, early course, maybe within the last 2 weeks of the AK, you are good to go for the transplant. But beyond
Mm.
it, it all depends. And anyway, a patient with AK going for a transplant has higher risk of developing post-transplant renal failure, may require a dialysis post-transplant too, when compared to those patients without AK going for a transplant. And the role of combined liver kidney transplant in ACLF, again, it's a big, there is no strong evidence to say, but
Mm.
people again consider if there is a definite underground background chronic kidney disease where your EGFR is less than 30, proven EGFR is less than 30, and no, those are the patients you go for a thing and combined liver kidney transplant. And also when you feel there is a dialysis requirement for more than 4 weeks if a patient
Sure.
is having a AKA processing. But this scenario in an ACLF patient, who requires dialysis for more than 4 weeks is usually a very sick patient. Whether he'll
Mm.
be good, he's not a patient like a decompensated cirrhosis with requiring AK and dialysis. So
Mm.
these rules, whether they are applicable to ACLF, is a big question.
So a couple of questions again with related to coulimic nephropathy. So how do you diagnose it? I still I understand there is still no clear-cut diagnostic modalities for that. And what do you consider is best for it? Is it TPE or a dialysis or a SLED that is better in managing coulimic nephropathy?
Bulimic nephropathy is similar to like hepatorenal syndrome. It's usually a diagnosis of more of an exclusion. There are specific indicators. What you say, patients develop you can say this is probably likely due to bulimic nephropathy. But most of the cases in AKI in ACLF is all mostly it is multifactorial. You can't say this is the exact reason. By your simple urine analysis will say in bulimic nephropathy you have bilirubin cast in urine,
Okay.
which is specific for coulimic nephropathy.
Okay.
If say in ATN you have multi-ground cast,
Mm-hmm.
in HRS you should not have practically you should not have any cast. So that is there, and there is a specific biomarkers for coulimic nephropathy, the specific biomarkers for an ATN.
Mm-hmm.
So these are the all in the research is not widely available, but there
Yeah.
are markers to say this is polemic, this is ATM. Okay, but of what current practice is your urine examination showing significant bilirubin crystals and the cast as well as a high bilirubin, and the patient correlates with their onset of nephropathies with the correlating with the peak of bilirubin, usually considered as polemic. Also ruling out the other causes.
Yeah.
And
And what do you think ATP versus SLED for this?
And coulimic nephropathy, since the pathogenesis is a high bilirubin, TP
Mm.
should be the first modality, and
Okay.
need for SLED or other CRRT is based on the renal, like based on the requirement for the dialysis. That is just a substitute for the renal function. But that for the treatment of coulimic nephropathy, plasma exchange or even the bilirubin filter, that even does good effects for the coulimic nephropathy.
Yeah. Okay. Great. Yeah. So, any questions from the audience side? I see a couple of things in the chat box. So, would you recommend high volume plasma exchange?
High volume plasma exchange is always for the acute liver failure. Even now, the acute liver failure people are moving towards a normal volume plasma exchange. For ACLF, it's always normal volume plasma exchange, that is replacing exactly 1 liter for 1 liter. So that is what we routinely follow.
Mm. And role of testosteroids in septic shock in ACLF in the ICU. When do you consider? If you consider the current evidence, there are no specific evidences with regards to ACLF patients because all ICU studies have encompasses both cirrhotic and non-cirrhotic, while the cirrhotic population is obviously less in most of the studies. So use of testosteroids can be extrapolated from the non-cirrhotic patients as well. So when there is refractory hypotension requiring more than one vasopressor, I think it should be the time where to consider testosteroids. And there is nothing specific for ACLF patients in the ICU with regards to testosteroids. And next question is, what optimization must be done before taking these patients to OT or ICU procedures? And how aggressive should we be correcting the coagulopathy? So optimization, obviously these patients will be requiring optimizations on a multiple organ function front. So those need to be sepsis, management of sepsis and optimization of frailty, sarcopenia states and coagulopathy correction. I don't think there should be a need for aggressive coagulopathy correction here if there is no bleeding concern as evidenced by your point of care coagulation testing. So ROTEM or tech-based correction should benefit these patients. This should obviously be weighed against the fluid optimization or risk benefit and then to be given just because we don't need number corrections, we just need to have a qualitative function of the coagulopathic parameters. That's what I think. Anybody would from the floor would like to add any further points? So certain statements, especially regarding use of decreased dose of intraoperative steroids at the time of reperfusion and cutoffs for GRWR have been made. Even post-transplant immunosuppression modifications have been made. For some of these require more evidences. If anybody from the audience would like to add some points regarding this, we'd be happy to receive it. So I think these are some areas of further research which we can plan and which can assist us provide a better picture in formulating guidelines for ACLF patients. And of course, these need more research and data in the future. So I think with this, we can conclude our session today. Thank you, Dr. Naveen. Thank you so much for taking the time off and joining us today and for your valuable comments and opinions. Thank you, sir. Dr. Anindita.
Thank you, Susan. It was and thank you, Naveen. So very excellent presentation. I mean, it's very difficult to cover Kyoto consensus in such a short time. I would recommend that everyone read the paper. I mean, the paper is really good because we all are very confused regarding the EASL recommendation, APASL recommendations, and all the recommendations. But the paper has definitely made it very easy for us to at least come to a general consensus about it, especially the therapeutic window, the ARC score. These are actually quite informative. So thanks, Susan. I mean, and there are a lot of points you have given us which still need to be dealt with and all in this consensus. So thank you so much. Yeah, very
Thank
well presented.
Thank you. Thank you. Thank you so much.
So thank you so much to all the interviews present here. Clint is really glad to have all these brilliant people to get a session today. And I hope you all had a seamless experience. So with everyone's permission, I'm concluding the session in here for today and looking forward to host you again. Thank you so much, everyone.
Thank you.
Thank you. Good night.
Good night.